Welcome to another episode of LIMBWatch series with Diabetic Foot Files. Today we are joined by the amazing Jason Ayers. He is a RN, a wound care nurse, innovator, and inventor dedicated to advancing the care of chronic wounds. He is the developer of a patent topical oxygen therapy kit that combines warm antimicrobial cleansing solution with localized topical oxygen delivery. His work focuses on improving the wound healing environment for patients with diabetic foot ulcers, peripheral arterial disease, venous stasis disease, ulcers, and other chronic non healing wounds. He is a registered nurse with over 25 years of clinical experience spanning over wound care, medical surgical nursing, pediatrics, gastroenterology, and osteotomy care. He began his nursing career as a wound care nurse in a long term facility and currently serves as an osteotomy education and wound care nurse, where he continues to focus on advancing the treatment of complex wounds. He's definitely an innovator in this field of wound care, and he has presented through this new innovation, three scientific posters at both the Symposium of Advanced Wound Care in Charlotte, North Carolina, and the Wound Osteotomy and Continence Nurse Society, the annual conference in Indianapolis, Indiana. He's also preparing a journal article for publication in the Wound Osteotomy Continence Nurse Society journal, highlighting his research and clinical innovation. So in this episode today, we are welcomed by Jason Ayers, and he's going to discuss the science behind the topical oxygen therapy, the inspiration for his invention, how this technology differs from existing wound care approaches, and where he believes this innovation can make the greatest impact in limb preservation. So welcome, Jason.
Thank you so much for this opportunity. I'm a fan of the show, been watching it for a bit, and I really appreciate the chance to come on your show.
Amazing. Thank you so much. You're so kind. So, Jason, tell us about yourself and your journey into wound care nursing.
I'm in the middle of a three-generational nursing. My daughter's a nurse as well. She's currently getting her master's degree in nursing, and she's very proud of her. She's one of my co-authors on my papers and the upcoming journal article. She's helping out quite a bit for me. Also, my mom was a retired nurse. She worked in long-term care and state survey work and state board of nursing. We lost her during COVID to long COVID. She was always an inspiration to me. Originally, I had worked in industry, and I think that helped a lot with coming up with this product, understanding how to make products. And I had transitioned into nursing, and my very first job was at that long-term care facility right after getting my LPN degree. And I worked there, and just as soon as I started that position, the wound care nurse had left or went to a different role. And right out of nursing school, I went straight into wound care. And that was my first job, and I fell in love with doing wound care. Several attributes of wound care I just passionate about. Everything from the prevention of the pressure injuries and teaching that to seeing the healing. I had a gentleman I got real close to, was one of my first patients. I had a stage 4, and I was able during that year to watch it progress and heal, and the satisfaction of that healing that we can help promote. And I always say too that I find it unique with wound care patients versus a lot of general nursing. When I get my wound and my patient in front of me, that becomes the whole job, and the whole world is to get that one patient healed, bring about a healing, get those tissues to growing, and all about the patients and get to know them and helping bring healing.
No, it definitely is a very personal, hands-on field. So how did you get the idea for this oxygen-powered hydrotherapy system? How did it originate?
Well, it came about with a lot of the challenges that we see taking care of the foot ulcers. Um, with a lot of the challenges we have with the infected wounds, the abscesses in the feet, a lot of times they'll get puncture wounds with the diabetics. And I work in the acute side currently, and I work hand in hand with my good friend and podiatrist. And he's co author on my papers as well and poster. And he has been such an inspiration with this whole product. With a lot of the wounds that we were seeing for a problem, it's so difficult to clean and get a diabetic wound cleaned out well enough. And self care with a lot of the patients, a lot of times will, well, it's the one wound on the body that the patient walks on.
Mhm.
And they, well, a couple of my case studies on my one poster with a classic diabetic wound. I walked in the room to take care of the gentleman as he was barefooted in the hospital room with drainage. And it's like, sir, we've got to get this covered.
Mhm.
And able to do a treatment on him straight from that condition. But those conditions, a lot of what brought me to this, looking for a way. My podiatrist, Dr. Haverly, when he came to me originally, is what brought about this ideal. Is he came to me and his statement was, Jason, there's just nothing on the market right now that facilitates debridement and cleaning up some of these infected wounds like the old fashioned hydrotherapy. And by using old hydrotherapy to get in and move that fluid about as part of that cleansing process, it's typically enjoyable to the patient. It's one of the most pain free debridements, if you can say that, for patients. And like my podiatrist said, there's just at this time, there's nothing on the market that acts as well as some of the old hydrotherapy did. And I always get tickled when I tell my story of coming up with this, especially at the conferences, because right about now is when a lot of the older nurses like myself will kind of roll their eyes and uh, a little bit because the old hydrotherapy had such a bad reputation. The old therapy was showed to be linked with so many cross contaminations in the different studies. I've heard stories of so many nurses talking about how difficult they were to set up and how difficult they were to clean, to fill, and it was riddled with a lot of problems. So my doc came to me and wanted to look at that. And I was like, well, I can't really go back to the old fashioned hydrotherapy because it's so currently outdated. And that led me down the road of, well, if I can't go back to the old way, maybe I can reinvent the old way. And that led me to the oxygen part of this because as I started trying to come up with a method to cleanse these wounds, I was looking at the old fashioned, more old fashioned way, using with electric motors, propellers, pumps, plumbing. And that is just too difficult to clean, too complicated, too much power. And it dawned on me that in the walls of every one of my patient rooms throughout the hospital, I have an oxygen hookup with pneumatic pressure to it. And the flow of oxygen coming out of one of those regulators is honestly all the power that you need. A lot of old techniques utilized large electric motors for higher PSI, which is questionable about causing damage to delicate granulation tissue as well. So, by using just the gentle flow of bubbles going through an antimicrobial solution, it dawned on me that that would be one of the best ways to generate that hydrotherapy, generate the agitation of the wound cleansing solutions in a way that was comfortable to my patients.
Oh, wow. Okay. So how many prototypes did you go through before developing the current design?
Lots. And all this has just flown together for us to be at this stage just from last summer. Last summer was about when my doc came up to me and posed that question. And where I was primary caregiver to my father before he passed with dementia a few years ago, I actually had O2 setups and O2 concentrators and wound care supplies here for him. And probably the first few months, I did arts and crafts here on those supplies. I always joke about the field of wound care when I have nursing students with me that I'll introduce it to them as the arts and crafts hour of nursing. We will take whatever we've got and combine it in ways to make it fit that individual wound and that individual patient. So that was kind of the challenge I took on with this. And I sat down with different supplies and started coming up with different patterns and for my nurses to use and some of the cuter processes of the prototypes I've gone through trying to develop this. I originally started off with different shapes. I think the first one was a square, and then I did a circle. I started cutting nasal cannulas and doing a Y shape, and I wound up cutting and making heart shaped ones to see how that would work here. Wound up making lollipops and L's, and it dawned on me that I could do something having to do with, well, what it is. And I started to make a raindrop. And what I wound up with, which is kind of funny because it works so well, everybody asks me why I have a yin and yang or a swirl on the package in my product. And it was actually one of those eureka moments when I came up with that shape because not only does it, honestly, it looks nice for the market then or the ideal of the aesthetics, but by doing a swirl shape, I actually wound up making a larger area at the end of it for the majority of the bubbles to come out. But it wound up that by doing that swirl, it followed the natural curve of the oxygen tubing. It added padding to the length of the tubing because I didn't want anything hard to touch my patient's wound. By using the materials that I've used in this, it's all everything that touches my patient's wound is already approved wound dressing or wound materials that we use every day. The swirl shape that you'll see in my posters and then the product or the website itself, by using that tail end of that swirl, a really interesting safety feature entered in that I was trying to pre troubleshoot everything for my patients that might be using this. And that's by if I had went with a solid circle, that's the same shape as all the Charcot foot patients typically.
Ah.
I didn't want anything expelling pressure or air that would match the shape of a wound. So by doing this swirl pattern, it gave me that circular shape for the bubbles to come out as the whirlpool feature or the agitation. But if I have a patient who's impulsive and stands on my padded bubble device, my tail of that shape works as a natural pressure relief. And
Mm.
it's interesting because when you push, if you try to push on it and block the oxygen flow, the oxygen will go to the point of least resistance and shoot out the backside of the tail. And it puts the line to the side. And so that's how I came up with the current design for it or the current prototypes. And I've got it put together in a ready to go kit with mixing instructions and cleansing pad and such as that. But I'm still every day I'm kind of trying to perfect it a little bit better for my people.
Oh, wow, that's so interesting. So what exactly happens when the oxygen bubbles move across the wound surface?
Okay. So we're still very young into this. This is moving so fast for us. So we're working on as many studies as we can get done to help answer those questions. I believe from the pictures and the case studies that we've seen, I believe it's a very similar to any other topical oxygen therapy. I believe we're generating I believe we're generating from what I've seen in my cases, probably a combination of effects. There's some classic studies on hydrotherapy and the whirlpool that was done when it was more popular that shows an increased reduction of symptoms of ischemia in the wound and
Mm.
vascular dilation on those studies for the classic hydrotherapy. There are some studies out that I find as a cornerstone almost to wound care that talks about the warmth of the wound bed
Mhm.
and how keeping warmth in the tissues and the exposed capillaries can speed healing. One study in particular I love shows that you cause a reduction in healing times just by too frequent of changes by exposing the wound bed to cool air, causing a constriction of the capillaries. And then the oxygen, with all the research out there on topical oxygen therapy, I believe all those studies would be relatable or shows potential on this as we move forward with it. So I believe there's several things happening there with my case studies as we've been able to document those, which I believe the oxygen is always a good thing. It's helping
Mhm.
to bring that to the wound surfaces and shallow there. But I'm hoping we move forward to test out that just the warmth of using a warmed antimicrobial solution to be powered that movement and irrigation by oxygen will help demonstrate those healing properties of the warm tissue to help hopefully dilate the tissue, the capillaries, so we have better blood flow, a warmer extremity to help generate the downstream flow of blood is all potentials that I see that in my case studies.
Oh, wow. So, what changes have you observed in diabetic wounds after the treatment?
Some of the most surprising to me is how fast a simple, gentle movement of water in my case studies have been able to help generate a cleansing or a debridement. Honestly, I was surprised at how quick just a gentle flow of an antimicrobial solution with oxygen was able to help clean. It's been I see a lot of softening of the skin, like in the callus areas, which helps with the debridement on the calluses. I see a lot of, in a lot of my pictures on my case studies, I see a lot of an improvement of the color of the skin. I see a decrease in drainage. I've had some patients that have came through with these case studies that just had, of course, working acute care, I see a lot of the worst of the worst. And some of my patients had so much yellow drainage and so much odor with some of these wounds. And being able to do that antimicrobial warm solution with its agitation just helps so much with the drainage and the odor and what I would suspect is biofilm in some of these wounds. Yeah,
Okay. And I remember some of the case studies you were mentioning gray and purple wound edges becoming pink. Can you explain the significance of this finding?
absolutely. Again, we're looking at the potentials, and I'm hoping for more case studies to show. I had two patients in particular that really stood out to me as being remarkable as we're trying to move forward on showing the benefits. And on my posters, if you see those are the one that actually had a toothpick injury and one that had a failed amputation site of the great toe. The patients was very complicated on those two by the fact that they had severe peripheral arterial disease right along with their diabetic foot infections that they had. One gentleman in particular stood out, and bless his heart, he had stepped on a toothpick lodged in the carpet, and about 3 days later, he sought medical treatment. And we had so much infection. My podiatrist had done an IND, and the blood flow and the infection just we had so much eschar forming. And in the
Hmm.
wound in the picture, you can see the purple tissue extending out from the darkened area. And that one was one of the ones that was most shocking to me on immediate results that we was able to see. And it was one of those case studies where I took the before picture, I did my 15-minute oxygen hydrotherapy treatment, took more pictures, I went down to my office and I was like, oh my, this purple is rescinded.
Hmm.
And that one in particular, if any of the other practitioners looks at the picture, I was truly expecting a large amount of amputation on that one. And current state, I believe the gentleman has has not undergone any amputation with that injury.
That's great.
Mhm.
So this therapy could potentially reduce the progression towards amputation.
Yes, I believe so. Of course, we're still showing that out, but the basic principle in all wound care and preventing amputation is we need to get these wounds closed as quickly as possible. And through good care, cleansing, biofilm is shown to greatly reduce the healing factors in these wounds and slow down healing. And I believe by using a method like this to as any debridement method helps to cleanse away biofilm and the microbes and the drainage. A cleaner wound heals so much faster, and debridement helps to heal wounds so much faster. And the quicker we can get wound to a point of healing and covering that, I believe can really help on the prevent the amputations.
That's beautiful. So we already know sharp debridement remains gold standard, but like we have patients that have peripheral arterial disease where it's not recommended, and we have to find other means of debridement. So how does this approach compare and help disrupt the biofilm through the hydrotherapy approach?
Okay. I believe this is, well, in classic hydrotherapy is just a part of what's in the toolbox of the practitioner, whether it's sharp debridements or new ultrasonics or the pulsajets or a mechanical or the enzymatic. My hope is that this will become another tool in the provider's toolbox. I think sharps will always be a gold standard. Now, I've had some really good results with this to where I've been able to see the patient ahead of my surgeons is for the RNs. And Tennessee may be where I'm located, maybe one of the more conservative. An RN or a wound care nurse is actually not permitted to do sharps debris.
Mhm.
So, for a comparison for me, this has given me a really good tool in my toolbox to be able to get a lot more mechanical debridement done
Mhm.
even before the debridement
Mhm.
and kind of be able to be more autonomous as a nurse.
Okay. So you would consider this something to bridge before sharp debridement? Just like how you were just saying, the autonomy before the doctor could see the patient possibly, or do you see it replacing a certain form of debridement?
Again, I think it potentially could be one of the tools in the toolbox for the practitioner
Mhm,
because there is so many debridement and all of our patients are so unique and wonderful in their own way.
mhm,
There's so many different kinds of ways. I've had patients that couldn't stand to be touched, and I wasn't able to do a lot of like the meta honey or the other types of debridement that way. So some patients work better with the enzymatic or the slow autolytic debridement. Some patients are better with the mechanical, with the sharps, with the pulsajet. I'm hoping this will at some point fit right back in, which this was at one time a standard of care. And with the risk of infections and everything at the time, this has kind of fallen out of practice or become more considered outdated. But my approach to this, I believe, has fixed the past problems that hydrotherapy had as one of the forms of debridement, which is the cross contamination.
mhm.
My kit and my product that I put together and my treatment is all patient specific. It's a one and done disposable kit. Speaking as a nurse, I've made a joke to a couple of people who's asked about infection risk, and I'm like, honestly, it's a fresh open package and an antimicrobial solution. If a patient gets a hospital based infection and when this was used on, somebody probably didn't wash their hands.
That's understandable, yeah, because it's in a sterile pack. Yeah. So, can you describe a typical treatment session?
Oh, absolutely. Of course, every patient is so different that we treat depending on what the doctor or my podiatrist wants in particular. I've been using this with multiple solutions, everything from bottled to mixed on the spot. All my solutions, I like that. In my practice with acute care, I have several rooms that I go see. I will typically take my kit in, and again, my kit has a kit and instructions and patient education put together on how to mix the most common solutions for care that my podiatrist and other podiatrists seem to order. It also has a debridement pad with it as well for after the hydrotherapy is complete, that a nurse will have it right there to be able to start the cleaning process for all the softened tissues that's ready to be cleansed, and again, the crest and the biofilm and the other things that might be able to be mechanically debrided away. And then the bubble or the agitation device itself that's self-adhesive and easy to apply. So when I go into the room, I always like to use a warm solution. Sometimes I'll warm it ahead of time for prep, or if the solution's already warm. When I go in and set my patient up, my device is already pre-cut as a standard for the typical disposable bath basins that all facilities have at their disposal. And I've developed it to where you can simply just peel the backing off of it, and it has a self-adhesive back, and you're able to just mash it in perfectly within a bath basin to be able to match that to have speed so a patient or nurse can be ready to go with it. If it's a patient that has another type of wound, say up on the leg from venostasis, or you're wanting a deeper solution, sometimes I will use a plastic liner and I will just stick it directly to the plastic liner, and then I'm able to use any container that I would like to do the soak in for my patient and keep a patient centric surface that nothing else has touched, and able to use a varied other containers that way. So once I stick it into the bath basin, typically is what I use,
Mm-hmm.
I'll fill it up with my solution. I'll start the treatment. Oxygen flow for the treatment varies to the patient. One side note of it is if I'm just after the hydrotherapy option with this, I am able to power this actually off of a rudimentary nebulizer pump that
Oh.
patients have anywhere. I think they're like $30 on Amazon if a patient needed this with just the hydrotherapy option. If you've got a wound that you're needing cleansed with this, there's no reason you can't just use regular room air and get the same mechanical debridement. The little cheap hydrotherapy pumps that are in so many patients' rooms in long-term care facilities and in home health, yeah, this will power it. So I will typical setup and treatment. I'll set my patient up. We'll get them to bubbling. A typical session is about 10 to 15 minutes. And the reason I always recommend that time frame is I don't want to over soak, and
Mm-hmm.
the air coming up through the oxygen may be cool or it may be room temperature. So I don't want my solution to greatly decrease in warmth. So about 10 to 15 minutes seems like the golden time on that to be able to keep the appendage warm, get enough airflow and water flow around that wound base. And that gives me just enough time to step next door, put on a couple of Band-Aids to the next patient or a couple of dressings on the next patient. I'll come back in. Patient will be done and ready, and I'll do a debridement cleansing with my little pad and dry the area off and do whatever standard dressing change has been ordered on that patient.
Oh, wow. So how do you, from the patient perspective, what's your feedback from the patient after treatment?
I'm so sorry, we lost connection for a
Oh,
second.
yeah.
Could you repeat
No,
that question?
sorry. Yes. What feedback have you been getting from the patient after the treatment? Like, oh, wow, that was easy. Oh, wow, that was painless. I feel pressure relief.
Exactly. We typically, when I tell my patients what I'm going to do, I nicknamed it my spa day treatment. Especially my little ladies get excited. Some of my men may be a little bit more gruff about it, but they have all enjoyed it. Well, to say enjoy a form of debridement may be carried too far, but they've yeah, they've enjoyed it. They've said it doesn't hurt for the most part. Of course, there's people you can't. Some wounds are just so painful,
Mhm.
but They have all enjoyed it. I've even had one patient on my posters, there's a finger I had done. And the gentleman was a really hardworking individual, but he knew with that finger amputation when I came in to debride it, he's like, hold on, let's get some pain medicine, can we?"
Yeah, yeah. Mhm. Exactly. Yeah.
I did him for about 15 minutes on the bubble treatment. And at the mark of 15, when I went to take him out, he didn't want to be took out. He's like, "This feels good. This is working."
Oh,
And
wow.
he actually caused me to keep him in for about 20, I think it was on his. But his was a significant surprise to me as well on the effects. Meant to, his, he was a worker here in this area and was very unfortunate. Um, and then necessitated the engine to be running. And he dropped a tool. And before he saw it, reached out to catch the tool. The belt and pulley system caught the end 90% of the finger past the first joint and amputated in the belt and pulley system of the car. I saw the original pictures, and the whole wound was just coated in car grease and belt grease.
Oh,
He came into the ER department and got good treatment there and instruction. And when he left, he actually did not come back for follow up for about 10 days. At the time he was readmitted to me at the hospital, he said he did not have the money for follow up to another doctor's office. And the traditional teaching of leave a wound open and dry is what he followed for the amputation of the end and went back to work in construction moving rock. So that was a particular interesting case for me. The wound itself was completely coated in a black looking eschar mixed with all kinds of foreign debris. He was originally held NPO from ortho to do surgery on, and I was able to do this treatment preoperatively before the ortho came in. And I was actually able to remove about 80% of the black stuff on the finger. Again, I encourage people to look up the poster or the case study that's been published. And my ortho came in. He's like, "I don't know what all you did when you cleaned it for us, but that looked good. I'm canceling the surgery."
oh, wow. That's
And
impressive.
yeah. And then I got a second treatment in on him the next day before he got to be discharged.
Oh, wow, that's impressive. So I do have another question. Is there an absolute contraindication for this treatment? It's like this, I don't recommend this for a certain type of wound or patient.
Of course, always. And what I would say on this is always follow your healthcare provider's advice, your wound care giver's advice. For me, I always go back to there's an old rule of thumb in wound care I was taught, and that's to keep a dry wound dry and keep a wet wound wet. And for example, on diabetic foot ulcers, especially on the heel, the standard is if it's dry, stable eschar, it's typically best not to debride it. And that would be this any form of debridement on your dry, stable eschars. Therapy was originally considered a standard of care for mechanical debridement of such wounds. And I'm kind of hoping since we've fixed those issues and we're showing a potential of how this may be very comparable to the original forms on when it was used well, that this may be something that might be widespread in the future. The and again, keep a dry wound dry. You don't want to introduce an infection by having too much moisture. But
Hmm.
at the same time, I see so many wounds that come in that patients or home health nurses are afraid to touch and afraid to clean. And sometimes, too, they kind of carry that to an extreme. Sometimes some things need a little cleaning.
Hmm. No, I think I agree with you completely when it comes to that. Totally agree with you. So where do you see this technology in 5 years? And like possibly you might need a certification course for this or, like just a course to learn how to use the treatment?
Right. There'll be, of course, with any new or reoccurrent therapy. There's always a learning couple of an old therapy like the old standard of care. My hope is that within 5 years, this would be a new standard of care, a new tool in the toolbox for debridement, a new way to encourage that oxygen into the wounds, that this would be widespread. Right now, I'm so encouraged. We're doing case studies and looking at that potential. I've had case studies with one mobile wound clinic. Asked him when he done the first case study for me how it went and how he was administering it, and he's actually using it on a patient in a nursing home.
Hmm.
And he had supplies and set up and orders there, and he said he'd call before he got to the facility and told them to set it up and have them soaking, and he would walk in the door ready to treat and ready to cleanse the wound. I've had a few patients. I think it can be used well across the spectrum. In 5 years, I'm extremely excited for that approach. Honestly, one of the things that the industry looks for in new products is if something's catching traction or not. What's the interest in it? And I'm just been blown away for something that's not even a year old yet. Won't even be a year old until this fall. I think November was probably the first time I used it on one of my patients. And in that time, I've already got enough case studies to be published and three posters. We're working on this journal article, been reached out to and in discussions with about four major companies right now that's actively messaging back and forth with me that we're looking at. I've had another gentleman that's been an absolute angel coming alongside of me, helping to encourage me and helping me open up some doors on that side of things. And I for something so new, I feel like this is almost like a snowball going down a hill. It might be a very large snowball yet, but the traction I'm seeing behind this is just really picking up speed and momentum. And I'm very excited for the prospect of where this could go in 5 years.
Oh wow. Yeah, no, it sounds amazing. I'm very interested and maybe in the future. I could be like, yeah, I remember him and he spoke on the podcast. So we're gonna do our rapid fire for closing in. So what is your preferred method of debridement? Sharp, enzymatic, autolytic, or mechanical?
I would say mechanical, and that's, well, for one, that's my devices category. But besides that, again, as a wound care nurse in Tennessee, I'm limited on some of the options I have. And I love to be able to clean a wound and see the difference I can make on getting rid of that scar and any odor, etc. And a lot of times the mechanical side just goes along so well with the other forms, like with the mechanical or with the enzymatic or the autolytic, because those are good forms of debridement. But with those dressing changes, you've got to have a good nurse getting in there and getting that wound bed cleaned. And even just in a dressing change, that little bit of mechanical debridement during the dressing change helps to stimulate those growth factors.
Mm-hmm.
Uh, you caught my attention on a recent podcast. You had called debridement the magic wand of wound care, and that's true. The more you stimulate those factors, a lot of times that's the faster the wound will heal. Getting that biofilm off, getting those factors activated within that wound base, that blood
Mm-hmm.
flow.
That's so true. So what is your favorite antiseptic slash antimicrobial for wound cleansing?
Oh, that's like asking about a favorite cola flavor. I think it depends. It depends on the day, honestly. Fourth poster with one company on working on a hypochlorous solution. Actually, I'm excited about that in particular because I took on another challenge with this because would the volume needed for a whirlpool bath be act as a limiting factor? And I've actually figured out how to use a plastic liner with my device and use almost a nesting technique within the basin that I've done a couple of treatments here recently of using anywhere from about 500 cc's to just 1 liter of solution. So that's been able to able to use the hypochlorous solution. And I use a lot of hypochlorous solution. Different patients are different things. If I have a very overly infected wound, I am a little old school. Been doing this 25 years. I still go back to a lot of the Dakins, still a lot of the acetic
Okay.
acid. Those overly infected wounds work really well. Sometimes on my solutions with this, when I'm trying to do a quick treatment on a patient, I'll mix up betadine, just like we use a lot of times with the Pulsovax and surgery, and do a betadine scrub depending on how infected the wound is.
That sounds great. I love me some betadine, so can't go wrong with that. What's one wound care myth you wish would disappear?
Well, after my long story about my gentleman with that finger amputation, I wish people wouldn't dry out wounds. I wish people would keep them covered. That gentleman was such a case study for that myth of leaving a wound open to air, especially the end of a finger being amputated like that. I have to address that so many times, it feels like, about letting the wound scab, letting the wound dry out. And it's like, I tell my patients all the time, I was like, if you stop and think about, we want these tissues to grow. And what environment does life and nature grow the best in? Do they grow the best in a desert, or do they grow the best in a jungle? In a jungle with a moist environment, you just have an overgrowth. And somewhere in between, you need the right warmth in that wound bed, the right moisture, and the right things that's necessary for life. We need what's necessary for life in that wound bed to promote those tissues and those cells to grow.
Oh, wow, I really love that. That's the great thing about this is, like, hearing everybody's perspective, but I absolutely love that. That's the first time I've ever heard that, and that's so incredibly unique. So, thank you for sharing that perspective. And if you can describe wound healing in 3 words, what would it be?
Oh, 3 words. Actually, what I say for most of my patients and most of my career is what wound me up in it is just basic TLC, tender
Oh,
loving.
nice.
And that's kind of my take on nursing. I love to be there to help bring healing, help bring comfort to my people. I had a discussion just this week with a patient that was having a lot of pain with a wound, and he was trying to get some pain medicine. And I was like, "Sir, I'm more than happy to go be your advocate and get you some pain medicine." I told him when I worked the surgery floor, that was one of my favorite parts of the day was actually to give pain medicine because I knew what it would mean to that person's being having that relief. And same thing with wound care, a little tender loving care to these wounds and to these patients can bring about a healing. It might save a limb. It can change a person's life. Just the pure basics.
Oh, wow, I love that. Maybe that could be your, like, slogan, maybe for the hydrotherapy, because I love that. That's amazing.
Thank you.
So, as we wrap up this episode today, I'd like to give a big thank you to Jason Ayers, if I'm pronouncing it right, for joining us and sharing his incredible journey, his incredible innovation, and his incredible passion for advancing wound care. Conversations like this remind us that progress in limb preservation doesn't come from one breakthrough alone. It comes from clinicians who are willing to ask the right questions, develop great ideas, and continue to strive to improve patient outcomes. And thank you for tuning in to LIMBWatch by Diabetic Foot Files. If you enjoyed this episode today, be sure to like, subscribe. Definitely share this episode because I feel this is the cutting edge of innovation. And definitely check out Jason Ayers' website. It's going to be linked at the bottom of his episode description so that you can see the actual case studies, but they're actually incredible and remarkable. And today we raise awareness, advance education, and work toward the common goal of saving limbs and improving lives. And until next time, this is Diabetic Foot Files reminding you every step matters, everyone has a story, every limb is worth saving, and take care of your feet because they take care of you. And thank you again, Mr. Jason Ayers.